now we do have an awful lot of questions in the chat. So Sarah's been beavering away trying to group them into where there's been several questions along the same vein. And so, Sarah, are you ready?
I sure am.
And Tina, would you like to decide who should answer them amongst your panel of experts?
Not a problem.
Lovely. So just to give you guys a heads up, we've got a bunch of questions about FMD itself, what it is, who gets it, is it progressive, so on and so forth. Then we'll move on to some hopefully quick questions about medications, migraines and artificial hormones. And then we've got a question on exercise. And then we'll end up with questions about the regions, the clinics and the registry, if that sounds okay to you. So to start off with, Karen and Bex, if you wouldn't mind just keeping an eye on the chat in case anything else pops in while we're doing this. So I'm going to try and group these first questions together. So first of all, do we know how many people roughly may have been diagnosed with FMD in the UK, and also how many children?
Okay, I can probably start with that question because in all honesty, the answer is we don't really know because we don't have a UK registry. Centres will say that they've got a handful of cases. So some of the big centres, all those centres that are listed, the specialist ones, will all have a handful of cases between them. So it's quite difficult for me to give you a more honest and accurate answer. I'm hoping that our UK study will be able to give you a better answer.
Okay.
So it may help to know, I suppose, the US registry has got more than 2,000 patients and the European and international one has got more than 1,000 patients. So the American registry has certainly been recruiting for 10 years, if not more, and the European one around 10. So I guess that gives you some flavor of how many cases have come forward. Again, these will only just be from certain centers that are either more likely to encounter such patients or have a vested interest. So yes, I hope that helps to answer that.
There was a follow-up question from somebody who said, I'm a bit confused, is it rare or do 5% of people have it? And I think that's in reference to the comment on the slide about prevalence of incidentally discovered FMD. I think that was among healthy kidney donors. I know I've read that fact and I share that fact on the SCAD support page quite often. It's true, it was found in up to 6% of healthy kidney donors, wasn't it?
So yes, that's very true. And there are some patients who do come to my clinic who have been incidentally found. In general, people in whom it is an incidental diagnosis have, well, very little trouble from FMD in general, because it's either very mild, very benign, and it's just an incidental finding. So yes, so when you look at dedicated radiological imaging, you do encounter it a little bit more. As to whether how many of those are symptomatic, it will be a smaller percentage than that. Aine, I don't know if you perhaps want to add anything to that.
Yeah, no, exactly what Tina says. So it's unlikely for someone who's fit and well and healthy to have a CT angiogram or an MR angiogram. And the closest surrogate we have for that are the healthy people who come forward as donors. So they will have a CTA or an MRA as part of their workup to be a donor. So it's really hard to say for definite how many people have FMD. But the donor population is a nice surrogate in terms of healthy individuals.
I guess also the question thereafter is, can these individuals donate their kidneys? And that perhaps needs a whole separate discussion to it. But that's something we could perhaps do at one of the subsequent patient events. I can give you a little bit of a synopsis on what the literature has shown. And I've written a paper with Alexandra as a co-author on some guidelines for centres, bearing in mind all the evidence out there on which incidences are regarded as safer to donate your kidney and where we would say it's best to try and avoid.
Okay. So then there's three next questions are kind of connected as well. So I'll mention them all. Do you know, are people born with FMD or do they develop it? Firstly. Secondly, could FMD be progressive? So, for example, patients perhaps excluded at some point, would they perhaps one day in the future meet the criteria for FMD? Perhaps if they see their symptoms progress, you know, they might want to be rechecked. And then another question, which is kind of related, which was, do we think that possibly FMD might affect all medium-sized arteries in the body, but perhaps it's only really obvious or apparent in a few? So is it a sort of a wholly, would you expect it to be a wholly sort of systemic thing, even if the manifestation of it is only apparent in certain areas?
Okay, difficult questions. The first one mainly is the difficult one. So regarding at what age you develop it, or was it always there? Very hard to know. What we do know from registry data is in people who've got the unifocal, in other words, a more concentrated area of narrowing, they present earlier. So if you've got a unifocal narrowing, you're more likely to present with symptoms because of that, either because of lack of perfusion, in other words, blood flowing through that particular vessel, less blood supply, pain, etc. So we do know that they present younger. As to whether this is something that you've always had, it's difficult to know. So we certainly know that children who present tend to have a more aggressive course. So if the younger you are, the more sort of striking the features are, then often you've had a more sort of dramatic entry into the world of FMD. We are looking at follow-up studies, and as Dave Adlam alluded to as well, it's only the minority that will go on to have successive episodes of either dissection, aneurysm, expansion, needing intervention. There are certainly patients in whom that will happen, and why they have a slightly more aggressive course isn't entirely known, but what we do know is that people who are smokers, so whether you've ever been a smoker or you're a smoker now, are more likely to have, if I can call it, a more aggressive course. So it's certainly something that we try to encourage, because smoking will interfere with the health of your blood vessels. So that's probably the best way I can answer that question in terms of when do you develop it. We don't know for sure, but usually the younger you are, the more striking the features are noted to be. The second question was regarding is it in all vessels of the body? So from the international consensus guidelines recommend a once-off top to tail imaging so that we can specifically look which vessels are more affected than others. And when you look at those images, you can usually tell which blood vessels are affected in a way that might have any relevance to you. So from a macroscopic radiological presentation, you can usually tell which vessels are affected. However, there is some fascinating work coming out of a group in Italy, part of the MEDIA study, and a group in, I think it's Pisa, specifically in Italy. And they have found that when you image the radial artery and neck artery, so radial arteries are the arteries in your wrist, as it were. So if I just sort of show you in myself here, okay? When they image the radial arteries of patients with FMD, they notice that the blood vessels have got something called a triple signal. You know, instead of having just sort of like a double signal, there seems to be this extra signal noted on an ultrasound scan. So of course that leads you to the question of, well, does this mean that all the blood vessels might have some subtle changes? Why then some are more likely to manifest with ballooning aneurysms or narrowing stenoses? Isn't clear, but this is fascinating work. It also, to me, opens the door for perhaps screening patients with non-invasive methods in the future, or perhaps if you cannot undergo a CT scan or have claustrophobia and unable to go an MR scan, or whatever it might be, this might open the door for that. So this is fascinating, interesting work that's come out. Interestingly, some of the other work with genetic aberrations of blood vessels also show that you might have a slightly more thickened carotid, that's the neck arteries. So watch the space. I think this is something to still be proven. But in terms of what's practical and relevant for you is that unless your radiological imaging shows something specific, it is irrelevant whether there is FMD anywhere else. It's irrelevant. I don't know if perhaps if Aparna, my neurology colleague, or anyone else feels I've missed anything with that answer. That was a long-winded answer, sorry.
Yeah, Tina, I agree with you, because most of these patients, some of these patients can be asymptomatic totally, and sometimes there can be an incidental bruit heard and one of the carotid arteries, and thereby suspecting in a relatively young, healthy, people with a bruit incidental finding, and thereby suspecting, getting all the scans done, and confirming the diagnosis of FMD. So it's quite difficult to say who would develop these symptoms, and if you have a suspicion of having FMD, it's always better to get a head to toe kind of imaging to see the arteries affected, and thereby we know the extent and also the severity of the disease.
That's really fascinating, and I love the idea that one day we might be able to get ultrasounds of our wrists and have some sort of screening program. Wouldn't that be nice? There've been a few technical medical terms mentioned in the presentation this evening. So Tina, could you do a very quick, plain English guide to a few symptoms, a few names, please, for me, just so that we've got it on record so people can listen back to it. So the first one is ischemia.
Okay, so ischemia refers to not enough oxygen getting to a particular organ. So that would be because there isn't necessarily enough blood flow. So a good way to explain that is if you've got a blockage of a blood vessel. So for example, if there's a blood clot within one of the vessels to the heart, anything that blood vessel is supplying, and there's anything downstream of that blood vessel, will suffer ischemia. So ischemia means not enough oxygen getting to that particular organ or part of the body.
Okay, then the next two are embolization and thrombi.
Yeah, so a thrombus is a blood clot, essentially. So you might have heard a deep vein thrombosis that they often talk about on flights and things like that. So thrombosis is just a generic term that there is a blood clot. So I feel like I'm hogging the stage here. Maybe Anya, do you perhaps want to answer a bit about embolization or embolus as well?
Yeah, so embolization is when something breaks off that clot and moves distally to another vessel. So like Tina said, if you have a deep vein thrombosis, which is a clot in your leg, the concern is that it might move to one of the bigger blood vessels in your chest, which we call a pulmonary embolus. So a clot affecting your pulmonary arteries or your lung arteries. So the similar phenomena you can see in the arteries, whereby if you have a clot formation, so where there's lots of platelets coming along, and because of the blood flow through the vessel, a little part of that blood clot can break off and move to smaller vessels, and instead of narrowing the vessel, because it's a smaller vessel, it'll clot it off or block it off completely.
Fantastic, thank you. And I think we just covered perfusion just now. I think that was flow, was that right, Tina?
That's right. Yes. Fantastic.
So moving on, you showed a diagram, Anya, I think, of a balloon angioplasty in a renal artery, in a kidney artery. Could you talk a tiny bit about that? How does it happen? Can it cause damage? Are patients generally awake when you have one? In the SCAD community, just as a little bit of background, we've all got used to the idea that if a patient can be managed conservatively, i.e. medication only, that is often the ideal situation. That stents and bypass obviously are essential if somebody is unstable, but that if patients are clinically stable and can be managed conservatively, that's a good thing. So perhaps you could just explain a little bit about why somebody might need balloon angioplasty, how it happens, what it's like to be given one of these treatments.
Of course. So similar to SCAD FMD, we try and manage, and most of the patients are managed medically without the need of any sort of invasive intervention. However, if you have one of these focal narrowings, so the really tight narrowing, particularly going to your renal arteries, that can lead to very high blood pressure, which can be difficult to treat with just medication alone. So this is really a small cohort of patients where that renal artery is so tight that there's very little blood supply getting to the kidney, and the kidney responds by driving up your blood pressure, trying to get more blood supply. If we can't manage the blood pressure with medication, or if it's impacting your actual kidney function, then we do what we call a balloon angioplasty. So that involves threading a little guide wire up into that blood vessel, and that can be done either through your radial artery or through one of your femoral vessels. You are awake for the procedure, similar if you were to have an angiogram for a heart attack. You're given some sedation for the procedure, but you're not put asleep as you would be for a major surgery. So that guide wire goes up to the area of the narrowing, goes through the narrowing because it's very slim wire. And then when the wire is in there, it inflates a balloon to try and open up that narrowing. So in comparison to when you have a heart attack where there's a complete blockage of a vessel or a really tight narrowing of a coronary artery, they try and deploy a stent to keep that narrowing open. What we know in FMD is that because the vessels are a little bit more friable or a little bit more delicate, they don't deploy a stent because you're at higher risk of a tear or a dissection in the renal artery. So they put in a balloon to open up the narrowing and then take out the guide wire. And in majority of cases, that is enough to cure your hypertension. And very few patients need repeated angioplasties or balloons going into their artery, similar to what we see in SCAD. So it's a very small cohort of patients that will need it, and it's in an even smaller cohort of patients that will need it again.
That's really helpful. Thank you very much indeed. Slightly different question, but something particularly in the SCAD community that a number of people report back is that when they have their head-to-hip scan, quite a few people are found to have enlarged aortas, enlarged descending aortas quite often. So are you aware of that generally in the FMD community, or is that something that's more SCAD community specific? I'm not sure it's a question you can really answer, but have you observed it even?
So we've observed it in only a tiny percentage of patients. So if anybody does have an enlarged aorta, this to me triggers subsequent referrals. So the first thing I would want is a cardiologist's opinion. It may be relevant in some people to do genetic testing for conditions that can affect the aorta, because there's a certain sort of percentage over when you've gone over that, it does trigger a referral to some genetic tests. But it is the minority in the FMD community.
Yeah, I agree with that, because FMD, it mainly affects the medium-sized arteries. So if something like an aorta is affected, I should look into some other secondary causes that might be causing aortic diseases, like more diseases affecting the large vessels, like a Takayasu arthritis or some kind of a vasculitis.
Okay, thank you. There was talk earlier on about red flag symptoms, which mean that a patient should seek urgent medical attention. I think it would be helpful just to go over those again. I know vision changes, mini stroke symptoms were mentioned. Is there anything else that people should be on the lookout for, in this area?
So I will again ask my colleagues to chip in here, but I think it depends which part of the body is affected. So if you've got any stroke type symptoms, the acronym FAST, there's quite a lot of advertising around that. That to me would be something that should trigger you to seek help. From the cardiac, the heart perspective, anything that's suspicious of a heart attack, so chest pain, often it can be sort of like a central crushing chest pain, sometimes even back pain rated to your jaw, your neck, sweating, things like that should trigger help. From the kidney perspective, because the kidneys don't as such cause pain, if I can put it that way, the way that your kidneys warn you that something's going on is by pushing your blood pressure up. So if your blood pressure is particularly high, so that might manifest with a severe headache, which again would be part of the fast symptoms. But if you've got headaches that just aren't going away, that's something that should be checked. I think those are sort of the most general red flag symptoms. Is there anything else you would add to that?
Yeah. Apart from that, anyone with a sudden onset of slurring of the speech or imbalance while walking, especially attacks here, that points to the posterior strokes because of the involvement of the vertebral artery, which is much more commonly affected in FMD patients. Whereas the blurring of the vision is much more commonly seen in the anterior circulations because of the carotid, which is again one more commonly affected artery in FMD patients.
Okay, well, that's a good list of things for people to look out for. As Dr. Adam was saying, we don't want people to be worried all the time, but it's more, we like to talk about in the SCAD community, knowledge is power. So if you're aware of what might happen and you've got that tucked away at the back of your head, then if those things do start to happen in your life, then perhaps you can do something about that. Okay, that's really helpful. Thank you very much. So moving on.
If I can just add some support to that, Sarah, I think that it's only natural that the majority of the patients that I speak to, or that myself and Aparna will speak to, are hypervigilant and are anxious. So there is certain comfort in the fact that fortunately recurrences are extremely rare. So I think there is certainly comfort there. I appreciate if it's happened to you, you don't see that as rare, and perhaps that gives you no comfort at all. But please be assured that it is rare, and rather know about something than not know about it. And I think that's why we put so much emphasis on things like stopping smoking, high blood pressure management, just generally keeping fit and healthy, because all this does help.
Yeah, absolutely, 100%. And it's exactly the same in the SCAD community. So are there plans to further investigate genetics? Is there anything you can tell us about that? You shared some really fascinating insights in your presentation, but is there anything more you can tell us about what we might look forward to in the future?
Yeah, so there are certain groups that are already looking at this, and it's more challenging than you might imagine, but how they've tried to approach it. So there are fantastic groups in New York looking at some of this, as well as in Europe. And again, the genetic knowledge is advancing rapidly. It's really hard to sort of keep up with all the new tests and how you understand things. But some tests involve just doing the wider sort of like panel of tests in a group of patients' DNA and see what flags. And then you can sort of see, oh, there's signals that this particular gene seems to be flagging a bit more commonly than others. So that's often one line of query that then will lead to subsequent investigations. But in terms of what genetic research is taking place right now, the factor 1 gene is the way I can explain it best. And again, Dave Adlam has given a brilliant YouTube talk on just this in an accessible way. So this is a part within a gene that is a risk factor. Okay, and it's a risk factor that might predispose you to a high incidence of SCAD, to FMD, but also carotid artery dissections, migraines. This particular genetic variation, however, is very common in the general population. So there is a bit of fear at the moment that this test is not good enough to be a specific marker. So I have had requests come to say, can I not have this factor gene test? It's not available. It's only in the research realm. And that's very much where it is right now. It's giving us a clue that we need to follow that trail of investigation. But that is nonetheless interesting, because this particular factor 1 gene risk allele, if I can put it that way, if you have got a particular type of variation in it, you might be prone to SCAD, etc. But conversely, if you've got this particular variant, it actually is seen as protective from atherosclerosis. Now, isn't that fascinating? So it means that if you have got this anomaly, you might be more prone to FMD, etc., but you're actually more protected from atherosclerosis, which is by far more common, by far more generalized, is part of the aging process. So that's a really interesting association.
Absolutely.
Also, sorry.
We do have a video, Dr. Adam, talking about that. And when we'll probably do a summary of what we've discussed tonight, and we'll make sure that video gets shared again. So it's a really good point to make, Tina. It's getting that perspective right, isn't it? Be aware, but try to control hypervigilance, because that doesn't help anybody.
Yes, no, very much so. And there is lots of other research going on. For example, there's work on something called proteomics, looking at proteins that break off into the urine. Can we pick up anything from there? There's studies in, for example, zebrafish. So there are both lab and clinical studies and work on blood and urine to see what information we can gain. So at the moment, the UK isn't doing that yet because we're still just trying to get a registry together with patients and a database. But the plan is that any serum or blood samples or DNA that we get, we will be sharing with the labs that have got the facilities and the know-how to analyze larger groups, so that it's more meaningful.
Fantastic. So last very quick question about FMD. You mentioned in your presentation that tiredness was a common factor among FMD patients. We've had a question, have many FMD patients been diagnosed with something like chronic fatigue? Are you aware of that? Is that sort of higher than you'd expect to find in the normal population?
So because we have quite a high proportion of patients who've had many strokes or strokes, there is certainly post-stroke fatigue, which I'm sure Aparna can talk to us about. There are certainly patients who've got chronic fatigue syndrome. Again, I wouldn't say it's the majority of patients, but I have got patients with it, and it is very debilitating. It's also quite hard sometimes to seek expert help in that regard. There is also I would say a high proportion of patients with pulsatile tinnitus. That's like that whooshing sound by your ears. And we're very fortunate to have the Wishes website that we can signpost patients to. That is, again, peer support and a source of comfort there. Sorry, Aparna or Aine, is anything to add to the tiredness one from your side? You probably said more than me, Aparna.
Yeah, we look into a lot of patients in the general neurology clinics who present with a chronic fatigue syndrome and kind of a fibromyalgia syndrome, but I haven't seen any of these patients with associated FMD, but I do agree with the post-stroke fatigue, especially in young patients with the FMD. There can be association with the long-standing, fatigue because of the ongoing symptoms, especially with this irritating tinnitus kind of symptoms or chronic migraines causing these non-specific, chronic tiredness and conditions. But in general, chronic fibromyalgia syndromes, I haven't seen any specific association with FMD in general. Yeah.
Thank you. Thank you. Have you had many cases of FMD running in families? This is a question the SCAD community asks a lot, and the general answer they get is that typically it's not a familial thing, though we do have a tiny number of brother pairs and sister pairs in our community. Do you see FMD running in families?
So the interesting thing is that the longer the registries go on for, the incidence continues to drop. So what started off as a sort of almost a 10% incidence of family history in the French registry has now subsequently dropped to around 4%. So my understanding is that it's around about the 4% mark in general in all registries. The important thing is to ask it. I think that's the important thing, is that you do need to ask, and then anybody who might have symptoms that are suspicious for FMD, it would help for them to be scanned, because I guess you can't conclusively say that there's a family history without that crucial imaging. Again, I have a handful of patients who have family members with that have either got some associated phenotype of FMD or might have had symptoms of stroke at a young age, high blood pressure, etc., but it does not turn out to be FMD. So I think the important thing is to ask it and to, again, follow that trail so that you can individualize the response for that person and their family.
Fantastic, thank you. I think and hope the next section will be much quicker. Medications, migraines, and artificial hormones. Pain relief medications for FMD. Generally speaking, I think we're all mostly told that non-steroid or anti-inflammatories are not a good idea. Are they okay if you really need them for a very short period of time, or are they an absolute no-no?
No, sorry.
Yeah, please go.
Yeah, for the treatment of migraines, especially for the acute migraines, I don't think triptans or serotonin agonists is a good choice of drug in FMD patients, because they act on the receptors called serotonin receptors in the walls of the blood vessels, which can sometimes constrict the blood vessels, increasing the risk of strokes in these patients. So that's not a good idea to prescribe triptans as an acute treatment of the migraines in these patients. We have several, safer options, like a short course of NSAIDs like diclofenac or brufen is still a good idea if there is no renal involvement in these patients. And with respect to the chronic, the migraine prophylaxis, we have several group of, drugs to prevent if the migraine attacks or so burdened with more than 4 to 5 episodes of acute migraines in a month, then probably we can put them on a chronic migraine prophylaxis with much safer drugs.
So there was a follow-on question specifically about migraine medicines. I'm not sure if I'm pronouncing it right, but bizotofen?
Bizotofen. So okay. That's again a serotonin agonist, which, as I mentioned, it acts on the receptors in the blood vessel walls, which constrict the blood vessels. So that's not a good idea to prescribe bizotofen, even as a shorter course. Yeah.
So a more general question is that if my GP or headache specialist is unsure about the best medication for me to use, who can I ask them to talk to? Is there a migraine specialist with FMD expertise?
I think usually they will send to the general neurology, pool neurology clinics as a referral, and thereby we see the clinic, the patient in the general neurology clinics. Initially, we start the treatment, and if someone remains refractory to the treatment, then only we do a referral to the headache specialty clinics. And we have several different newer options like CGRP receptor, antagonists, which are like a newer drug treatment for the migraine. So that will be decided if some patient fulfills the criteria for a refractory migraines, then they will be offered these kind of specialized, newer treatments in the headache specialties.
Thank you. There was a comment on one of the slides about avoiding fluoroquinolone, and could we have a little bit of information about what that is and why should it be avoided? And then there was a follow-up question, is hydroxychloroquine safe instead of fluoroquinolone?
So two totally different groups of medications. So fluoroquinolones are antibiotics, okay? And the common names that we will have in the UK will be things like ciprofloxacin, levofloxacin, and ofloxacin. So anything that ends in acin is a fluoroquinolone. Common can be used to treat things like urinary tract infections, for example. So that's one of our standard questions in our clinic. Now, why we have chosen to suggest avoiding these antibiotics is not because there is a strong association between these antibiotics and FMD specifically, but there are studies which show that these fluoroquinolone antibiotics can degrade or have degradative effects on connective tissue. And they might be important in how aortic artery aneurysms are formed and can rupture. So whilst this is not specifically where the FMD might be, we just feel, until proven otherwise, it seems safest to avoid any antibiotic that is going to have a degrading effect on the connective tissue of blood vessels. So fortunately, they're not the most commonly used antibiotics, but it's something that I tend to do as a standard practice. I just say, just avoid until we know otherwise. Hydroxychloroquine is different. So hydroxychloroquine is an anti-malarial, but also a disease-modifying drug in things like rheumatoid arthritis, autoimmune conditions. Obviously, it's had some heightened profile because of COVID. So it's a different medication. I'm not aware of any research that has any implications on FMD and hydroxychloroquine. So unless there's something I don't know about, it's not something that's flagged at all to me.
Thank you. It wasn't one that I knew of either. Question on HRT now. Certainly in the past and still currently people who are not so familiar, doctors who are not so familiar with FMD and SCAD, there are often conversations about not taking HRT because of the possible hormonal link that we, the connection that we're aware of. I know that Dr. Adlam is taking, and Dr. Al-Husseini are taking increasingly pragmatic views on the use of HRT, and it should be symptoms-based. And if you've got terrible symptoms, then you need to treat those symptoms, because those symptoms in and of themselves can be difficult for the patient and can have serious consequences for the patient. It would be really useful and helpful to have an FMD expert's perspective on HRT as well, please.
I couldn't agree more, Sarah. I think the important thing to remember is that you are a person first and somebody with FMD or SCAD, whatever, second or the third, fourth, fifth down the list type thing. So it's very much, you've got to take a pragmatic approach, because we don't have any evidence otherwise. So there's no firm evidence that contraception, IVF, hormone replacement therapy, or even pregnancy increase the development or progression of FMD specifically. So therefore, it is appreciably, FMD is more common in women. So there is research trying to understand, is this to do with estrogen and the receptors, etc. But we have to be pragmatic. It is a very individual decision, and it's something that we do discuss on an individual basis. I would support you take a pragmatic approach here.
Thank you. Exercise. I know, again, this is a very individualized topic, but could you give some general guidelines for people who have either head or neck related FMD or have FMD elsewhere in their body? Are there any general guidelines that you would recommend people follow?
Okay. I'll let Aparna go start with that one.
Yeah, maybe because the FMD is much more commonly, it affects the vertebral arteries, which pass through the the vertebrae, the cervical vertebrae. Maybe it's wise to avoid exercises which can hyperextend the neck, like stretching exercises or hyperextension of the neck to a greater extent, or something like chiropractic. Even that's contraindicated, because most of the times they might cause dissection of these arteries, which are much more fragile, resulting in a posterior stroke. So maybe, that's one of the things suggested.
And Aparna, do you get asked a lot about going to the hairdressers, for example, because that means that somebody's neck will be potentially hyperextended for a while? Do you get questions along those lines?
Yeah, definitely. That's the reason we avoid, particularly patients with vertebral dissections, to avoid something which hyperextend the neck. For example, yoga postures, some of the yoga postures you do, there is a lot of hyperextension. That's usually we don't suggest people doing that.
And would you say that if somebody did not have FMD that was visible in their cerebral arteries, or would you say for all FMD patients?
If on the imaging, if there is no evidence of a cervicocranial FMD, then I think that doesn't hold good for them. So it's the pragmatic approach is the individual based. If someone doesn't have a cervicocranial, we cannot, stop them from doing these exercises. So, yeah.
Okay.
From the kidney side, that would be the same. So in fact, we very much encourage exercise, healthy living. And in all honesty, the vast majority of the FMD patients are health conscious, fit individuals. So actually, we very much do encourage exercise. You just have to be mindful if you're somebody who suffers with very high blood pressure about, intense weightlifting. So it's just better to ensure your blood pressure is controlled before doing anything, sort of the more excess end of exercise. But otherwise, actually, we would encourage it.
Super. Some very quick questions about the clinics and the regions. So we're talking about cross-border referrals. Also, whether there is FMD expertise now in Scotland, in Northern Ireland, and in Wales. Should people be looking to get referred to clinics in these countries if they exist, or should they be looking to get referred to you in Salford? What advice can you give there? Yeah.
So I'm happy to see anybody is the bottom line. The issues are often just, as you say, the referrals. I'm going to throw a question back at you, because you mentioned that the Scottish SCAD patients have managed to find a loophole now to access care in England.
They have. That was via Dr. Adlam, and to be honest, all I know is that I think he did something behind the scenes, and it's now possible for them to be referred without a funding issue cropping up. So it might be an idea for you and he to have a chat about that.
Yes, okay. That sounds very promising. As long as I've got a referral letter, because we do our consultations by phone at the moment, it doesn't really matter to me where patients come from. And I certainly have spoken to some patients in Scotland. What I've done in Ireland, for example, there is Dr. Katrina Canning, who has an interest in FMD in Dublin. So I've referred patients to see her. Two of our co-collaborators, one in Edinburgh and one in Glasgow, are renal specialists, but with an interest in FMD. So I've signposted that way as well. So those are sort of the best contacts we've got if you're unable to access the Salford Clinic. But I will speak to David and see what he's done.
That's great. This is an interesting one, and I know it crops up a lot in the SCAD community, that's for sure. How can I get a head-to-hip MRI scan if my cardiologist thinks I don't need one because I've got low blood pressure?
So the first thing is that you usually need the 2 scans, because most hospitals can't do this in one setting. I know they can do them in some centers in the States, but you can't in the UK. So we tend to basically request neck up and neck down. It's sort of 2 separate scans. If your cardiologist won't do a scan, I don't see what the low blood pressure has to do with that, in all honesty. Having low blood pressure is not a reason not to have a scan.
Yeah, sorry to interrupt. I think that obviously there is not enough knowledge about and awareness about FMD, and I think a lot of medical practitioners' knowledge is based on renal FMD, which can result in high blood pressure. Therefore, if they've got a patient in front of them with low blood pressure, which an awful lot of SCAD patients are in that boat, sometimes we hear in the community that they tell me, I don't need this investigation because I've got low blood pressure. So is there an angle that as a patient we can push for? I mean, we've got a best practice leaflet for SCAD that we share, and we encourage our patients to share, show the doctor or the GP and ask them to follow best practice guidelines. Have you got anything else that you can suggest that we put in our arsenal for, for becoming better at advocating for our needs?
So the best thing is to get a referral to ourselves, because that's something that will then come as a direct request from us. And then patients can have that locally, but then the films will be transferred to us for assessment. So I would suggest that's something that we're certainly happy to help with. I'm just trying to think in terms of accessible information that you could signpost to. So there is something on the Radar website that we've uploaded that just signposts to the head-to-tail imaging. The British and Irish Hypertension Society also produced a statement. That was more to do with COVID, though, at the time of COVID. I'll need to double check if that covers the head-to-tail imaging. But yes, I think probably the most pragmatic is that either the GP or the specialist can refer to us for that question to be answered.
Fantastic. And one final question on that is, if my consultant wants some advice, do you have capacity to answer colleague questions?
Yes, that's fine. I find it's always easier to actually see the patients, or to at least get all their notes, that you can get a holistic picture and speak to them as well. But absolutely, we're all on the same side here. We need to work together.
Fantastic. Right. I'm very conscious that we're just past 9. We're on the last set of questions. There's just a few of them. It's all about the FMD registry. So hopefully people will give us a few more minutes to finish all this off. So can we be enrolled in both the SCAD registry and the FMD registry?
Yes, if you need to have FMD to be in the FMD registry. So whether you've got FMD and SCAD or without, you're eligible.
Fantastic. And the way that we enroll in the FMD registry, so for example, I'm now probably talking for the SCAD community, many of us got diagnosed with FMD at the same time as we got diagnosed with SCAD. Yeah. What should we do? How should we get our enrollment underway?
Okay, so the first thing is, if you're in one of the centres that enrolls, then they can enrol you. If not, and you've, as I said, been seen by Salford at any point, we can enroll you. If you are not in a centre that is part of the recruitment process, then that particular the clinicians with an interest, if they just get in touch with myself or Anya, we can put an amendment in to get their centre onboarded.
Okay. Is there a limit to how many people you're going to allow to join the FMD registry?
No, there's no limit, but all research has to have a shelf life. And essentially once there's more than 1,000 patients or 10 years, something like that is that right, Anya? That's what we've put, because you have to put an end date, and anything more, you just have to put another amendment. We're experts in amendments now, but yeah, as many as possible would be the ideal.
Just like to thank everybody who sent questions in advance and on this evening. It's been really, really interesting looking at all these questions coming in. And I'm imagining they've given Tina, Aparna and Anya a lot to think about. And we're really grateful to you for the answers that you provided. So thank you very much.
And thank